Thanks again for joining us today. I'm going to kick off with a few housekeeping notes before we begin. This webinar will be recorded and we will be sending a recording to all guests afterwards, so you have a copy. 2, we will have 15 minutes at the very end for Q&A. So if you do have any questions that come up during the session, please type them into the Q&A box and we will try to get them answered at the very end. And lastly, all participants are on mute. So again, if you have any questions, Q&A box is where you'll want to send them into our panelists. And with that, I'll hand it over to Dr. Hallberg to get us started.
Thank you. Thank you, everyone, and welcome today. We are glad that you're here to join us. I'm Dr. Sarah Hallberg, Medical Director here at Verta, and I'll be moderating this session today. Today, we'll focus on one topic, a new weight loss drug that was approved by the FDA on June 4th, just very recently, this month. Given the rising obesity rates, breakthrough clinical efficacy, and high sticker price for the new drug, we've gotten a lot of questions from health plan leaders and benefit leaders who are concerned about controlling prescription costs. So we've gathered the leading world experts in obesity, diabetes reversal, and employer benefits to break down this topic for you. We'll kick off today with Chantell, National Clinical Pharmacy Lead at Willis Towers Watson. She will be sharing a landscape overview and forecasted impact of the new obesity medication for health plans and employers. Next, we'll have Sami Inkinen, CEO and co-founder of Verta, sharing more on cost-effective alternatives for obesity and diabetes. Third, we'll have Hassan Azar, Vice President of Global Benefits at JLL, share a case study of how he was able to reverse diabetes and deprescribe medications in his employee population. Last, we'll be closing out with a Q&A session, and we're fortunate enough to have Dr. Robert Ratner joining us. Dr. Ratner is the Chief Medical Officer of Verta Health and the former Chief Medical Officer of the American Diabetes Association. Again, I want to welcome you, and I will turn it over to Chantell to kick us off. Thank you, Chantell.
Chantell, you might still be on mute.
Great, thank you so much. Sorry about that, Shannon. And I am thrilled to be here today. Thank you so much for the opportunity to kick off this incredibly important and timely conversation. I think that everyone is aware of how significant the obesity market is right now. Obesity is such a common chronic condition. We're estimating upwards of 40% of the whole US adult population is obese. And we're actually thinking that that might be higher given the pandemic and the impact that COVID-19 had on us over the past year. Obesity is a precursor to so many other conditions. We're talking about heart disease, diabetes, certain cancers, and especially for those people that are diabetic, we know that obesity is significant in those populations. I think the graphic to the right just really showcases the increased prevalence of obesity in every single state, more than 20%. And I don't think anyone would disagree that people that are obese tend to drive higher medical costs. We see that about $1,400 higher than those that are of normal weight. I think this, along with all of the employer things I'll touch on in a second, just knowing that this is a significant issue, we'll talk through a little bit about what employers can do to sort of think through some of the conversation points here. So where are we today in the weight loss medication market? I'm not even going to touch on OTCs, over-the-counter medications, the weight loss supplement industry. That's a $5 billion separate industry. But in terms of prescriptions that are available today, you may have heard of brand name products, Contrave, Adipex, Quizmia, Saxenda. There's also some generic available products as well. But really, these provide moderate weight loss. It depends on the drug. And they are really fraught with a lot of uncomfortable side effects. A lot of them have to do with digestive cramping and gas and oily stool, constipation, et cetera, anything from headache to increased blood pressure, sleep issues. So they're not used significantly at this point. Most of them are indicated in conjunction with a reduced or low calorie or low fat diet, increased physical activity, and some even have a body mass index threshold for requirements to use. So I will talk about that in a little bit, but what I'd like to do is just hone in on one specific class of medications, the GLP-1 agonists. And why I bring these up, there's upwards of 10 of them now on the marketplace. You'll see that largely they're available as a self-injectable that the patient does themselves. There is one oral product, and 3 of them are the chemical semaglutide. So you'll see different dosage strengths here. Most recently, most of them are approved just for diabetes, but 2 of them, Saxenda and the newly approved Wegovi, are approved for obesity. So you'll see those here on the slide. You can see the relative costs here. These are AWP costs. These are before rebates. But what I'd like to also sort of talk through is a little bit about the mechanism of action of GLP-1. It really does act in multiple regions of the brain. It regulates hormones and neurotransmitters and really allows patients to feel satiated and therefore regulate the appetite. So this is a class-wide effect. We see this with the drugs that are just used for diabetes as well. So just know that is a somewhat wanted side effect with this entire class, and the reason that the 2 are approved now for obesity. So when we talk about Wegovi, it was just recently FDA approved as in addition to a reduced calorie diet, increased physical activity for chronic management in adults who have a BMI who are obese of over 30, or if it's over 27, so they're technically overweight in the presence of at least one comorbid condition. So hypertension, high blood pressure, type 2 diabetes, dyslipidemia, so cholesterol. There were various trials for this product to get to approval, step 1, 2, 3, and 4. In the clinical trials, I think the bottom line is that this showed significant sustained weight loss of 34 pounds. So that's roughly a 15% change in body weight over 68 weeks. And the greatest change was noted really as an adjunct to intensive behavioral therapy with an initial low-calorie diet. So really significant weight loss, unlike we've seen with any other product to date. We haven't seen a weight loss drug be approved in the last 7 years. So that's definitely a benefit. Some risks include the adverse effects. They are things like some of the stomach issues I was noting earlier, nausea, diarrhea, vomiting, constipation. These are side effects that can be mitigated. This drug is given in lower doses and it's increased, it's titrated over a 4-week period. So sometimes these side effects can be mitigated by doing that slow titration. In the clinical trials, they were also the cause of some people discontinuing therapy. Not that many, but just note that that's in the background. There's warnings. I took all of this right from the prescribing information, including T-cell tumors, pancreatitis, gallbladder disease, kidney injury, suicidal behavior ideation, and that contraindications cannot use if you have history of medullary thyroid carcinoma, for example. So I'm not going to read everything, but note that there were some positive effects on metabolic markers. So weight loss, blood pressure, HDL, LDL, and there is 2 years sustained weight loss data available for the product as well. what I'd really like to focus on now is the fact that this entire category will boom over the next 5 years. So we know there's over 250 obesity drugs at various stages in the pipeline process right now. So we know in the next 5 years, for sure, the GLP-1 agonists are going to, that class will expand. And then GLPs in combination with other agents like glucagon receptor agonists, other brand new agents like an appetite regulating drug will be approved. So even before the end of this year, we can expect more activity at least. There is tirzepatide, which is expected, highly anticipated and expected to be submitted to the FDA by the end of 2021. And then, as I mentioned before, there's 3 semaglutide products currently approved. There is an oral semaglutide product that's currently being studied for obesity as well. So just know that this whole thing is in the background as well. This is only going to grow. When we talk about why this matters to employers, I think it's obvious, right? We talked about the broad impact and that over 40 to 45% of adults in the US are obese. Wegovi has an excellent clinical profile in terms of its efficacy. We want to weigh the risks and the benefits. So we talked about some of the risks as well. From a financial perspective, we think this is expected to cost relatively the same as Saxenda, roughly $15,000 a year. Again, this is before rebates. And based on the mechanism of action, may be an ongoing expense, a chronic drug. So just taking just a quick little calculation here, if an employer has 10,000 lives and if only 2 to 5% of the population use the drug, that could tack on an extra $3 to $7 million. So just, understanding that in the background. GLPs in particular, semaglutide, because there's products already on the market, providers are comfortable using this. We see, at least in the Willis Towers Watson Pharmacy Collaborative, 2 of the diabetes GLP drugs are in our top 10 for annual spend, Trulicity and Ozempic. In many of our employers that I work with, they even see other weight loss drugs pop into their top 10, again, depending on their population. So also what employers can do about this, what we think is, a good place to start is just to really understand where your current benefit design is set up, how it's set up. Are you covering weight loss drugs today? In our population in the Pharmacy Collaborative at Willis Towers Watson, 30 to 40% of our clients exclude weight loss drugs, and that could be due to cost. There is sort of an antiquated cosmetic designation around this. We all know that obesity is a disease and something that's not necessarily considered cosmetic anymore. For those employers that do cover weight loss drugs, it roughly costs them 40 cents to $1 PMPM. And again, that's based on their individual population, their drug mix, their PBM. So it's widely variable. If you are covering weight loss drugs, you really want to make sure that the drugs are being used for appropriate populations. So if you are working with a PBM, if you're working with a pharmacy consultant, I've been working with all of the PBMs, and I know for a fact that they will have utilization management criteria in place to make sure that this drug and other weight loss drugs are being used according to their label. So again, we talked about the over 30 BMI or 27, depending on the concomitant conditions, and also really wanting to understand. So we also know that they'll have quantity limits, for example, and even if they do approve it, it may be for a limited time period. Let's say approval for 8 to 12 weeks, and then reassess to make sure that that particular patient is seeing some sustained weight loss, and then they will likely continue that authorization. So there will be things in place. Do you want things that are more restrictive in terms of other additional authorization requirements to make sure that the diet lifestyle are being taken into consideration? That's also something to sort of think through and talk to your talk to your PBM, talk to your pharmacy consultants about. But what I really want to drive home here is to think critically about your existing obesity or prediabetes solutions that are in place today. You really want to make sure that they are effective, that they're engaging, that they're really they're addressing the underlying root cause of obesity. So you have to have something that starts with nutrition, diet, lifestyle first. And then it's incredibly important. I talked a little bit earlier about behavioral support and in the weight loss process, and making sure that that's built in the form of coaching, or if there are specific programs that really help support the patient from a whole. And these are your three really key things that you can do right now just to sort of set yourself up to have, a really comprehensive approach. So in conclusion, just for my section, just the takeaway really bullet points here. We obviously know obesity is a huge issue affecting 40 to 45% of adults. We know that it can be mitigated by preventative measures. We talked a lot about diet, lifestyle. There's other things like bariatric surgery, the medications. Certainly these GLP-1s are here to stay. We're going to see their use in diabetes and weight loss continue to grow over the next decade. We know there is a significant price point, even before rebates, even after rebates, with the accelerated growth of these drugs. We want to evaluate really the risk and benefit of having those in place. And then lastly, I cannot underscore just having that comprehensive, engaging pre-diabetes obesity strategy in place, and really wrap that around all of the things we talked about in terms of nutrition, lifestyle intervention, behavioral support. So with that, I think we can move on to the next section.
All right, thank you so much, Chantell. That is an awful lot to think about, quite a bit when you start scratching the surface. Next, we will have Sami Inkinen, CEO and founder of Virta Health, sharing more on cost-effective alternatives for obesity and diabetes. Welcome, Sami. Over to you.
Well, thank you, Dr. Hallberg and Chantell. An amazing presentation there. So let me just start by making the obvious statement. Nobody disagrees or questions that obesity is a massive and sadly massively quickly growing challenge in America. I think what is up for debate is, how do we solve this? What are the best approaches to solving obesity? And so I'm hoping to highlight a few things here that are not just pharmaceuticals. But given the what I consider American obsession to find a drug for every health solution, it's probably not a surprise that when some of these new class of GLP-1 drugs that had been previously used for type 2 diabetes was now approved for obesity, it's really not a surprise that this news got massive coverage in the media. And here's just a couple of examples. And what's the information that we know? And repeating a little bit what Chantell said, this class of drugs, GLP-1s, apparently works very well for weight loss as well, although the dose for weight loss was multiplied from type 2 diabetes care, but the data shows substantial weight loss, 33, 34 pounds after 68 weeks. But with that substantial weight loss, at least on a list price basis, comes a pretty massive price tag as well, potentially about $15,000, $16,000 per patient per year. And we don't yet know very long-term data, but it is very possible that this $15,000 subscription to this drug could continue for a long time, potentially forever, to keep the weight actually down. So impressive drug or class of drugs, but also impressive price tag, most likely. Well, given the American obsession on finding a drug to solve a health crisis, and given the size of the obesity epidemic, it's not really that unlikely that this new class of drugs would really become a quote unquote miracle drug that would be used by very large numbers of Americans. That's my guess. We will see what happens. But when I say large numbers of Americans, maybe you listeners know this, but to me, these are shocking numbers. We are getting close to 50%. We are somewhere around 45%, I think now, but close to 50% of American adults, so well north of 100 million people, are now considered obese. And at least technically, nearly all of these individuals would also now qualify for these obesity weight loss drugs. So it could be a massive market. However, historically, drugs as a solution for obesity, I guess it's safe to say two things. One, clearly they haven't solved our obesity epidemic. They haven't solved. So the drugs haven't solved the obesity problem. And then secondly, the penetration of these obesity drugs among obese folks have actually been quite low, under 1%. And one of the reasons it's been pretty low is that most of the effective or reasonably effective weight loss drugs have also massive side effects. And you can read here on the side effects column, you know, we're talking about birth defects, suicidal thoughts, even cancer risk. So many of the previous obesity drugs have had very substantial side effects. And that's one of the reasons they haven't really become widely popular. However, it appears that this new class of drugs, GLP-1s, while they also have side effects, they seem to be better tolerated than some of the earlier generation obesity drugs. And if you think about that, that could mean that a much larger percentage than 1% of obese individuals will be on these drugs. So that's good news for the market. Good news for the market, good news for the people selling the drugs, but question is who's paying the bills? And obviously it's health plans, self-insured employers, and of course taxpayers. So we just wanted to highlight the very pre-scenario. So if you are a reasonably large employer with 10,000 benefits enrolled adults, and we assume that 40 to 43% obesity prevalence rate, depending on the drug penetration, these type of new GLP-1 drugs could cost somewhere between $3 to $7 million. $3 to $7 million per year if the penetration for the drug is between 5 to 10%. So it's a pretty sizable additional bill for the employer to pay. Well, I spend a lot of time talking about pharmaceuticals as a solution to obesity, especially now that we have this new class of drugs, GLP-1s, available. But a good question to ask is this the only thing we can do? And is this the only solution? And how does this compare to other treatments? There are many ways to try to lose weight, but we wanted to highlight three here. So the first column, you can see results from the GLP-1 drug trials. Then on the middle, second column, we have bariatric surgery that has existed for decades. And then thirdly, may sound self-serving, but we have our data from our own Verta treatment that's a nutrition-based treatment is the third column. And so if you look at these three potential methods for obesity or for weight loss, you can see that they deliver roughly the same type of weight loss. We did not put the number for bariatric surgery, but it delivers very substantial weight loss. So all of these three can be very effective in helping people lose weight, but there's a massive difference in cost to the payer, side effects. Also, some of these treatments have or don't have long-term outcomes data, and I will share some of our Verta results. We now have data published at 3.5 years, and we're collecting 5-year data. And then perhaps most importantly, a good question to ask if you're an employer health plan, is this a short-term thing that will deliver long-term results? Or is this a lifelong thing that you have to be on? And we don't really know from the GLP-1s yet, but it appears that potentially people would need to be on these drugs very long term to keep the weight down. On the Verta treatment, we typically support our patients for 2 to 3 years and then help them to learn the habits to keep their weight down. So again, different ways to address obesity, and I think it's very important to have a comprehensive solution to obesity if you're an employer health plan. So just a couple of brief recommendations from Verta perspective to employers and health plans, which unsurprisingly is quite aligned with what Chantell mentioned. One, focus on helping your members and employees lose weight nutritionally as the first line therapy before going into ways such as pharmaceuticals that may have significant side effects and be much more expensive. And then secondly, it's very important when there are multiple options, different outcomes, different cost levels, to really reconsider the plan design so that you are driving and promoting the most effective solutions first. And then if there are people who can't be successful on that, then they have other options to consider. But I think plan design becomes even more important when you have these massively expensive options available in the marketplace. And so I wanted to finish off before we hand it over to Hassan briefly, since I mentioned the Verta results. What is it that Verta does? And I'll try to be very brief. So we address type 2 diabetes by reversing it, and then we also address obesity by helping people lose weight. The way we do it is a combination of two things. One, it is a 100% nutrition-based treatment. We don't provide any food products, but it's all through a behavior change. So one is a nutrition-based treatment. And then secondly, we are a provider-led telemedicine company. So we provide very intensive support around 2 to 3 interactions, not per year or week, but 2 to 3 interactions per day with our patients. So you can think of us as a virtual clinic that uses nutrition to help people lose weight. And when I say help people lose weight, I'm not going to talk about type 2 diabetes reversal outcomes here, but our patients lose substantial amount of body weight very rapidly within the first year. But most importantly, we now also have 3.5-year data. And here we compare average weight loss on a Verta treatment at 3.5 years, 7.1%, to the Look Ahead trial, the DPP trial, sponsored by the US government and NIH. And you can see that we delivered almost 2 times as much sustained weight loss at 3.5 years. So I'll just finish with one thought. Obesity is a big problem. Everybody agrees. Question is, how do you address it? Clearly, one size fits all is not the right answer. So there are many options. And I would encourage employers and health plans to think carefully, what is the thing that you put in front of your people first to help them with obesity, and then think about what are the other options that should be available for those who won't be successful on the initial efforts and treatments. With that, I'll hand it back to Dr. Hallberg.
Thank you, Sami. Next, we have Hassan Azar, VP of Global Benefits at JLL, to share a case study of how he was able to reverse diabetes and de-prescribe medications in his employee population. Hassan, thank you so much for joining us today.
Thank you for having me. Let's see, and I move the slide. So my name is Hassan Azar. I, as mentioned, the head of benefits for Jones Lang LaSalle. For those of you that don't know what the company is, it's a global real estate firm where we handle leasing and broking and facilities management around the world. We have about 30,000 employees in the United States that are covered in our benefit plans, plus all their dependents. So our healthcare expense and program is pretty significant. So like every other employer in the United States of any size, we're always focused on how to help our employees live a better life, whether it's through improving their health, managing their chronic condition, getting them to the right facility or the right provider at the right time. And today I want to share just a story about how, through our partnership with Verta, we've actually helped to improve the lives of many of our employees living with type 2 diabetes while controlling costs and actually reducing their reliance on prescriptions. The program, as we've seen over the past 2 years, have been truly transformative. And I think that you can walk away with this with a better sense of how medication deprescription and diabetes reversal will really make an impact on your population. So I want to start just by showing how successful the program has been and just give a real snapshot of a before and after, so to speak, of what happened with our A1C. So looking at the top line there, you see what happened prior to the program. Our only 15% of our employees were in a sub-diabetic A1C level, and we had the vast majority of our employees either heading towards metabolic issue or in diabetes. The needle obviously was not moving the right direction as these numbers were getting worse over time. And this actually led us to seek out a better solution and finding Virta, looking at their results and saying, I think that this is a solution we need, because what the current mode of care and standard of care that our employees were getting from their community providers wasn't actually making a difference for those employees or us as a company. So after implementing the program and a year into it, you see what's actually happened here. The green and red bars have actually reversed. So we have nearly 60% of our employees actually in sub-diabetic A1C, and a small number, 9% actually with over a 8.0 A1C. So tremendous results, just an incredible improvement in the health of this population. And I must say, a relatively short amount of time. So 1 year into the program and seeing those results really has led us to believe that this is the way that we're going to actually help take care of our diabetic population. So while the change in A1C really got our attention as the ultimate payer for all of these medical claims, the impact on cost was pretty remarkable. You can see here, so on average, our diabetic employees prior to bringing in Virta were costing us almost $20,000 a year. And that's, for those of you that know your numbers, that's a pretty significant amount of money. After 2 years in the program, the average cost of our employees in the program was reduced to just under $13,000, and that's a savings of about $6,500. And when we think about that over the total size of our population, and when I think about all the other employers out there that actually could implement this program, it's a pretty dramatic impact on the cost of medical care in the United States. And I will say this is the type of savings and lasting savings that employers have been looking for. It's something that I think is going to be around and going to set the standard. And when we look at all the other programs we buy, this is what we're going to be looking for. So how did we arrive at such meaningful cost savings? By ultimately improving the health of our population and reducing the reliance on medications just for this population. So what you're seeing in this chart is how much of a reduction there's been in prescriptions for patients who've been in Virta for a year now. And the results are pretty dramatic. In fact, 68% of the prescriptions for these diabetic drugs have been entirely eliminated by the end of the first year. And how is this happening? It's happening as the patients improve their health, they drop their blood glucose levels, and they no longer actually need these medications to manage their diabetes. And you'll see that the line doesn't go to zero, and we accept that. That's obviously biologically, not every employee is going to be able to live without some medications. But what we're actually seeing is that in the majority of cases, the dosages are being reduced. And so we're getting an impact on all the people in our population. So 77% of our population that was in the program or on a diabetes medication have eliminated at least one medication in the first year. And here's a breakdown by drug class of what's actually happened here. So you can see across the board in all these classes, we have a reduction in the number of prescriptions for this group. And then you can see on the right there, when we extrapolate that across the average cost of these by month and per year, it's a pretty sizable impact on us as an employer and on the out-of-pocket costs for these individuals. Virta, what's interesting about these is that it's not just a cost issue. Virta improves the daily lives of all these individuals. They're focused on prioritizing deprescribing medications that have a higher risk of causing side effects. And they also take into account the individual lifestyle goals of all these employees and the out-of-pocket cost impact. So it's a win-win for both the company and all the employees when we see this reduction in prescriptions. And then digging deeper, just looking at the insulin usage, we've reduced the total amount of insulin prescribed at 1 year by 77% for the employees that are in the Verta program. And 46% of the JLL patients had insulin completely deprescribed by the end of the first year. So what we've seen, we've heard from our employees that the actual thought and promise of getting off of insulin at any point after being on it for years and years and years is a big motivator for our employees to stay in this program, to engage with it. And then they see the success of their coworkers that's driving further engagement. So it's a pretty remarkable program for us and pretty remarkable results we're seeing. And then speaking of results, when we look across our population as a whole, here's what's happened at the end of the first year. So we're seeing a total, or about an average A1C reduction of 1.5, where the rest of our population who's not in this program is seeing an increase in the same amount of time, and a pretty significant average weight loss of 9.3% body mass. And again, as I mentioned earlier, a reduction in the amount of prescriptions by 68%. So all in all, I consider this one of the most successful programs we have launched to actually take care of the health of our population. And it's getting the attention of a lot of employers across the country as a new standard for delivering better care for diabetics. We always look at our employees. We want to hear good and bad for our employees. We received just a tremendous amount of letters and emails and pictures from our employees. And here's just a sample of one of them. So Charlene here, and you see her before and after picture. After just 8 weeks on the program, she eliminated all of her insulin, reduced her A1C, and had a 17-pound weight loss just in 8 weeks. It's just tremendous. And we estimate the annual savings from prescriptions for her is about $10,000. So it was great to hear from her, and we've heard from many other employees about how much they value the program, and it makes us even prouder to actually offer something like this to our population.
Well, thank you, Hassan. I am going to ask all of the presenters or panelists and Dr. Ratner, I see you already there, wonderful, to join us again. And we're going to kick off a Q&A session. I want to thank everyone, first of all, who spoke today for joining us, and then also want to thank all the people who have sent in questions. We have a number of them, and we're going to try to get through as many as possible. So let's start off with a question for, I think, Chantell, this would go to you, and that is, what is the expected rebate for these drugs? With a healthcare cost of over $1,400 for the obese versus $15,000 for weight loss, hopefully it will be closer to a break-even point to convince employers to cover.
I think that is a great question, and one that I would redirect back to your individual PBM. That can vary significantly depending on who you're using, and I would think that they could help you determine net of rebates the return on investment, if that makes sense.
Yeah. Do you have any, because it's coming in another question too, any estimated cost to plan sponsors after the rebate? Do you have any sense of what it might be?
So, I mean, ranges we can estimate, but at the end of the day, it's individual contracts that are negotiated.
Okay.
So I'd hate to, provide a range and then be out of that range.
Absolutely. Absolutely. All right. How can employers measure and gauge the benefits of providing nutrition support and these prescriptions, excuse me, sorry, dogs in the background, for the long-term health of their employees that reduce absenteeism and increase
I wonder who's, maybe Hassan can add after my comment. I would just say that we've taken a conservative approach with our analysis on cost savings at Verta. So for example, the data that we shared, we just look at the hard medical claim savings. But that's a very good question. You know, if you lose 50 pounds, 100 pounds, whatever type of work you do, there's probably second, third order benefits for the employer. So maybe Hassan, this is probably your expertise.
Yeah, we assume it. We haven't measured it, but definitely you know, an impact on productivity, on other chronic conditions, and definitely we're seeing an increase in employee satisfaction for the employees that are in the program. They truly value it, and they're starting to value their benefits much more than they had in the past because they see that the company's actually caring about them and investing in them. So it's actually had a number of downstream effects.
Perhaps the best data comes from the diabetes prevention program, which had as a goal a 7% weight loss, but really the goal was to decrease the progression to diabetes. There's an economic analysis of the study that looked at both direct medical costs as well as the indirect costs, including productivity, absenteeism. And clearly, the prevention of diabetes with weight loss has a major impact on those indirect costs. I don't remember the numbers off the top of my head, but they're published in Diabetes Care and easily available.
Okay, great. Thank you. Question to Willis Tellers Watson. So I guess this comes to you, Chantell. What is the estimated cost of additional medications that would now be required to treat all of these moderate side effects? So I guess this is really a question about the intensity of side effects, and is this actually going to lead to increased prescriptions to manage those?
So that's a good question as well. I don't have the exact number for sure. So medications to treat the side effects is what I heard you say, Sarah. It's really hard to tell because, you know, it depends on, again, the drug and there might not be any drugs needed for some of those side effects. If it's transient nausea, you're probably not going to get a prescription for that. You know, some other things, you know, likely nominal, but, you know, it can add up. I think the bottom line is I don't have a specific number, but that is something that, you know, you can certainly go back and talk to your PBM about, or just, you know, get some general direction in terms of your specific population as well.
Yeah, my guess as a provider, you know, to kind of continue on with this is that it would be more the generic drugs, but the point is that yeah, I think the really important take-home point for this question is we're using a drug to combat a drug. And I think, you know, I bet Dr. Ratner would agree to me that that would be one of the ultimate issues there. All right, so this is for Sami and Dr. Ratner. What was the length of time that enrollees had diabetes that was reversed? The length of time that enrollees who had diabetes and was reversed. So I think this is a question regarding the clinical trial.
This may even be a question to you, Dr. Hallberg. If the question was about the duration of people coming in, the average duration since type 2 diabetes diagnosis was, if I remember right, was like 9.2 years. And it ranged between 25 to recently diagnosed. So we had the whole spectrum. Mm-hmm. You may remember better. If the question is how long people had diabetes in remission, the answer is it varies, but we are now just finished collecting 5-year data, and we published 2-year peer reviewed, and 3.5-year data is in abstract form. But Dr. Hallberg, you may remember.
Yeah, actually, so you're right. I mean, it was the average time with diabetes was really high. It was actually 8.4 years. But I'll just add in here that the other thing you said that was absolutely correct, which is the range. So we did have some people with newer diagnoses, but we also had some people who had decades into the diagnoses. And really important to understand that's almost like treating a different disease when you have long-standing diabetes versus when you have brand new diagnosis of diabetes. And our data was really on people who had very long diabetes, much more difficult overall to treat. I hope that answered the question. And the other one about if it's more about the long-term reversal data, will be hopefully coming out with that not too long. Okay, what is the typical structure with Verta in relationship to the existing plans within a company?
With existing plans, does this, I don't actually understand the question.
I think it may be, instead of plans, maybe programs within a employer. What is the relationship like?
Okay. Well, maybe I'll answer briefly, and then maybe Hassan can give the practical experience. So when we work with large employers such as JLL or Home Depot or Comcast, or many of these companies we work with, there's usually two types of implementations. Sometimes Verta is alongside with whatever has existed in the past for obesity or type 2 diabetes. So we're an option for people who want to reverse their disease. So sometimes it's that, and sometimes it's the other end of the spectrum where we say, we have all the capabilities to address pre-diabetes, type 2 diabetes, and obesity. We can do it all. So either one works fine, and it really just depends on our partners, our customers' preference and what they may or may not have done in the past. But Hassan, maybe you can elaborate on that.
Yeah, you're exactly right. It's up to the employer to set it up exactly as they see fit. So whether I have a bunch of other programs or wellness programs or well-being programs, we definitely don't want to have any overlap, and there would be nothing like this else that we offer. But the program sits by itself. Employees know about it. They know how to access it, and there's also integration with some of our other vendors too that works well. So.
Sorry, Hassan, this next question is also for you. If I could keep it going with you for just another minute. What were the incentives or maybe a mandate for JLL to get members to participate? Did JLL have any other benefit structure to encourage employees to join this program? Was there a carrot or a stick benefit design incentive?
No, neither a carrot or a stick, although I most of these employees that have been in the program that I talk to say that better health is a carrot by itself. So no, we didn't offer any incentive or encourage employees, monetarily to use the program. We just did a normal marketing campaign, shared information about it. And I've used Verta at 2 companies now and have had success doing this without having to incent it. What we do is share success stories across the company, so employees can see how well other employees have done when they volunteer the information and share some of those pictures. So the word of mouth has been the greatest incentive.
This question, thank you very much. Next question is for Dr. Ratner. Wouldn't Verta be a great supplement to prescriptions like Saxenda or Wegovi, since it would help retain their nutritional habits to support a lifelong change? Once participants' BMI is low, they typically have to come off these medications. And would it be best that they have good insights on how to maintain that beyond the medication?
Absolutely. I think that it's worth examining this in 2 ways. The data on GLP-1 receptor agonists has shown that even if you maintain therapy for 2 years, when you take away the drug, glucose levels go back up and the weight goes back up, so that you're not changing the underlying biology here. Having a simultaneous nutritional plan makes a big difference. And unfortunately, all of the studies in obesity have very poor nutritional interventions. Let me give you an example. The step 1 study using semaglutide in individuals who are obese without diabetes had a lifestyle component to it that was added to the semaglutide or added to placebo. The effectiveness of that lifestyle intervention was miserable. If you look at the placebo group, only 30% achieved a 5% weight loss in the placebo group, as opposed to 85% who were on the drug and the lifestyle. So I think it's important to be thinking in terms of the additive nutritional intervention. Give you an example. In a comparable patient population without diabetes, what we were able to accomplish at a year was over a 60% weight loss of greater than 5%, a 25% weight loss of greater than 15%. In my mind, that results in 2 conclusions. Number 1, any and all drug therapies that are being developed for obesity should have an effective nutritional intervention, both in the placebo arm as well as in the treatment arm. You got to have the best available standard of care. They haven't been doing that. The second is, from a clinical standpoint, you're absolutely right. It may be possible to essentially accelerate the weight loss with the drug in combination with nutrition, but then be able to remove the drug in order to maintain weight long term.
Thank you.
And just from Verta perspective, we would love to participate in a trial like that. There's no reason not to. And despite the fact that we talked about, or Hassan shared, the ability to eliminate unnecessary diabetes drugs, we as a company are not anti-pharmaceuticals. They're absolutely powerful tools, but particularly with obesity, as Dr. Radner said, these should be tools in combination with a strategy that delivers you long-term results.
All right. Well, Chantell, this next question is for you. From a clinical value medical expense perspective, if the drug is chronic, does it reduce the prescription spend compared to diabetes drugs?
Yeah, so that's a great question as well. We're looking into that. I think we don't have the data to support that yet, one way or the other, but certainly something we're considering, especially with this new product to market.
Got it. Thanks. All right, back to you, Sami, or Dr. Ratner. In a typical employer, if there is such a thing, what percentage of people with type 2 diabetes choose to participate in Verta when it is offered? The results for those who choose to participate are impressive, but I wonder about selection bias.
Well, I'm happy to start, and then Dr. Ratner can address the selection bias, because we can't force anyone to do anything. So the fact is, we make Verta available. We are not in a position to force anyone to do anything, and that's obviously by design. Typically, if we have really good marketing access that we work closely with an employer, we can get to up to third of the eligibles. Usually it's a little bit lower, but really what drives it is not so much who wants to. Many people want to, but as Hassan knows from his now 2 experiences, what is a bigger driver is how well can we get the word out there. And this is even, we can get to 1/3, usually a little bit lower, without financial incentives. Although I'm looking at you, Hassan, why wouldn't we try that? We should try positive financial incentives. But it's not 1% or 5%. We can really see activation in a double-digit percentages. So a lot of people raise their hand and say, if you can reverse my type 2 diabetes and I don't have to pay for it, and it's safe, why wouldn't I try it? But Dr. Radner, maybe you can address that sort of voluntary basis and how does it affect data?
Sure. Well, selection bias is always an issue. And just as a comparison, if you take a look at individuals who have just had a heart attack, a myocardial infarction, the recommendation is that all of those subjects should go home on an aspirin and on a statin. 6 months later, only 50% are taking it, despite the acuteness of a myocardial infarction and the medical severity. So we can't control what people do when they leave. In terms of assessing the value of the intervention, one of the ways that I would look at it is, what's our retention rate? In those individuals who opt into Verta, how many stick around? In our clinical trial, our 1-year retention rate was 83% on a nutritional intervention. Our 2-year retention rate was 74%. So clearly, patients are finding something acceptable. Now, I can't tell you what it would have been if we had taken a large unselected patient population and randomized them. But there aren't a whole lot of randomized trials of nutrition because it's hard to do and it's never blinded.
All right, well, thank you. We're getting close to the end of the hour, so I'm gonna throw out one more question for everyone, actually. Is this new weight loss drug not going to simply encourage patients to carry on eating maybe whatever they want because they think that the drug is going to lower their weight anyway? And I know we've heard this argument in the past when it comes to statins. You know, one of the worry with statins is we'll eat everything because the statin could lower cholesterol, and at least that's the patient's impression. So what kind of concern does anyone have with that?
I'm happy to go ahead and start.
Yeah.
The advantage of the GLP-1s is that they actually increase satiety. Patients will say, I never felt as though I was full. I'm always hungry. They go on the drug, they now say, I feel full for the first time in my life. So in general, they don't overeat. Like with bariatric surgery, if you do overeat, frequently the nausea and the vomiting become the behavioral piece to restrain food intake.
Anyone else have a comment on that one? Or we'll probably, as we've hit the hour, we'll wrap it up. And I want to thank everyone on the panel for joining us here today. And once again, thank everyone in the audience for taking a minute out of your day to discuss this really important topic with us. We will continue to bring you these webinars that are pertinent to the issues for employee health that you are concerned about today. Once again, a big thank you to everyone and have a great day.
Thank you.